Hello, everybody. My name is David Boone. I'm a general cardiology fellow here in the medical center at UT. I'm going to present a case titled When A to E is a Blur. I have no disclosures. So, traditionally speaking, the identification of shock has been based on hemodynamic parameters and clinical parameters such as blood pressure and physical exam. Recently, there has been a classification that was established by an expert consensus at SCAI, which announced a recent cardiogenic shock classification in an attempt to stratify those who are at highest risk of mortality. As you can see, those at risk will be those who have an in-STEMI, STEMI, heart failure. As they start to have hemodynamic changes, you'll see they are upgraded to Class B, and then Class C is your traditional shock. These patients have a lower mortality, but as they start to progress, you start to see a much larger portion of these patients will pass away. This is just depicting that, as you can see, classes D and E have a mortality that's in 40 to 60%, and then there's also a cardiac arrest modifier, which can increase that mortality almost twofold when on literature review. So, to show how this plays in real life, I'm going to present a case. This is a 47-year-old male, past medical history of hypertension, hyperlipidemia, diabetes. He presented to the county hospital with chest pain. They did an EKG, which showed ST elevations in leads 3 as well as V2 through 5. They started medical therapy with aspirin and Plavix. They do not have a cath lab, so he was life-flighted to the Memorial Hermann Hospital here in the medical center. On arrival, he was continuing to have chest pain, and as you can see, he began to have these hemodynamic markers which would indicate that he was in stage B cardiogenic shock. He was also in respiratory failure. At that time, we decided that we were going to perform revascularization, which is the standard of care, and we were going to do that radially because he has a STEMI, which is the standard of care at our hospital. There is some discussion whether or not you should perform a femoral access initially if someone is going into cardiogenic shock, as you could think about placing mechanical support such as balloon pump, Impella, or tandem up front. However, traditionally at our center, we use radial because of this mortality benefit. As you can see, the right coronary artery has some significant disease with 2 different lesions, almost mid to distal. Oh, back. And then the left coronary system had disease in the LAD, the left circ, and the ramus intermedius. For some reason, it's not playing the videos. Play.
Could you click on those panels to see if you can start the video?
And then the other one, please. So as you can see here, there's LAD disease, left circumflex disease, as well as disease in the ramus intermedius. This first video on the left has a better view of the LAD, which we believe was the culprit lesion. At that time, we decided to wire down the LAD and balloon. During this period, over approximately 20 minutes, the patient began to have worsening shock with his blood pressure dropping to a map of 40s. We were able to place the first stent proximally to that mid-LAD lesion, which was able to revascularize. We were able to get some revascularization. However, during that time, the patient began to deteriorate even worse. He flung his arm out, dislodging the catheter and the wire, and we had to perform he went into cardiac arrest, and we had to perform resuscitation measures for a few minutes. We did have resuscitation, but at that time it was decided that we were going to change our approach to a femoral approach due to the contamination of the field as well as radial spasm and the thought that we were going to add mechanical support. As you can see, we placed an Impella. We continued to wire down the LAD and proceeded to place the second stent. During that time, he continued to deteriorate, so we decided to do as much revascularization as possible during this procedure. We went for the the proximal RCA lesion, as you can see, we placed a stent in that proximal lesion. So as the patient progressed through this case, he began to require higher levels of vasopressors. He went from coming in with Class B and was now considered to be Class E or extremis. So the decision was made to place VA ECMO. So he was placed on VA ECMO, was stabilized, and transferred to the ICU. Here you can see his echo, which showed global stunning. This is the 5-chamber view, and then on the right you have your 2-chamber view. His hospital course went successfully. We were able to wean his pressors over the first few days and then decannulate his ECMO on day 4. The Impella was being weaned based on hemodynamics. However, he began to have polymorphic ventricular fibrillation, which we believe was secondary to ischemia, so he was taken back to the cath lab, at which time we tried to intervene on the left circumflex, but was considered a CTO based on the inability to pass either a run-through wire or hydrophilic wires, so that was left alone. We did intervene on the ramus intermedius, which resolved the polymorphic VFib, and he was decannulated on day 15. After that, he was transferred to the IMU, and then he was followed up in the clinic and was transferred back to the county system. Here's the PCI of the ramus. The classification of shock is important for us. It allows us to effectively communicate and identify patients at risk for shock. It gives us a rapid assessment of these patients so that we can better serve them and get them to the appropriate centers. There is limited data on this subject right now. However, there are cohorts coming out validating this classification. There will be need for future studies to validate as well as prospective trials. Most of this classification focuses on hemodynamics, but it is important to note that in their document they do emphasize the importance of physical exam as well as the biomarkers, the traditional biomarkers such as lactate, cardiac enzymes, as well as the use of a pulmonary artery catheter. So you can better understand the hemodynamic changes in these patients as well as the cardiac function. When you first encounter patients who are at risk for shock, the assessment should be on the realm of seconds to minutes. As you can see, this patient deteriorated very quickly and needed mechanical support, and decisions were made to upgrade that support very fast. Once you have the treatment in place, it's important to identify if the patient's either improving or worsening and reevaluate if you need to do anything else. It's important that we identify these patients because the mortality is on the range of 40 to 60%, as I said previously. This slide, I just wanted to discuss the nature of the hemodynamic to hemometabolic transition that can happen in these patients. Those patients in your traditional sense, and the shock in the traditional sense, are usually okay being supported by some sort of univentricular support or vasopressors. However, once they become in this hemometabolic or class D and E stage, this progressive/refractory shock, you need to start to discuss and determine if the patient will need something with circulatory support or biventricular support, such as VA ECMO. I know not every center has VA ECMO, so that brings me to my next point of shifting the focus. There was recently an ACC guideline or statement placed about cardiogenic shock and STEMI patients and allocating systems and processes that allow clinicians to get these patients to the correct centers. As you can see, this is discussing triaging centers all the way up to the advanced MCS. This is a perfect case to identify how the county system was able to identify a patient at risk and transfer them to a center with ECMO, ultimately saving the patient's life. So in conclusion, the most important things about cardiogenic shock are timing, identification, and early treatment, understanding the pathophysiology between the hemodynamics and hemometabolics, and then establishing systems and teams so that we can better serve these patients and get them to the appropriate centers and treatment. And with that, I'd like to thank Dr. Kumar and Dr. Jumian for this opportunity to present. If there are any questions.
So an observation and a couple questions. So I think as we authored this Sky document, this is exactly what we want, the kind of dialogue that we've heard, so that we then have the ability to have a conversation in which we understand who we're talking about. We fully believed that it was not something that was standalone or that in and of itself at this point that it was definitive, but rather gave us a much better dialogue for that. So thank you for reviewing that. You mentioned pulmonary artery catheter, but I would back up one point in that multivessel complex patient that you have that's stable, and simply looking at left ventricular end diastolic pressure after your diagnostic angiogram is often used as an inflection point. If you have a very high LV-EDP, that alone would be a trigger for going ahead and doing mechanical support at that point, and perhaps might have changed the course in terms of how you did that. But great case, and thank you for illustrating that.
Well, don't go away, Steve. So here you have a patient that rapidly transitioned in a way that may not have been predictable from ground zero. How do we really reconcile getting the patients to the right level of care centers?
Well, I think that's part of the challenge that we're trying to work out, right? Because the point is with ongoing, the question is this the result of ongoing ischemia in a patient who at that point was pretty stable? And if you're concerned about not being able to do support, do you just go ahead and do the intervention? Or was this the result of revascularization but no reflow? So as I looked at the angiograms, the one thing I saw is, yes, we had epicardial flow, but in fact it looked like microperfusion wasn't restored, right? I mean, you don't see the ground glass down the LAD and other things. And so at that point, after revascularization, I think the question would be what needs to be done beyond that. I don't think I answered your question, Mike.
Yeah, I asked an unanswerable question. Sorry about that.
Well, it's a very nice case, but I disagree a little bit with you when you say non-apparent on ground zero. I think on ground zero, we saw some signs that it was not a B, it was already a C, well established. I mean, we did not have time to measure things up front, because of course we did not have measurement cardiac output, but nevertheless, if you look at the heart rate, 128 or something like this, narrow pulse pressure, all these kind of things mentioned that the cardiac output was stroke volume was very low, and cardiac output probably also very low. You had also a patient who was somewhat hypoxemic. I mean, we had already 60% oxygen to keep the oxygen saturation. So all these factors already point out that this patient is in cardiac shock at that time. Lactate was not measured, and other things were not measured. PA catheter was not inserted. But nevertheless, when we look at the angiogram also, contractility was not very good. I mean, we saw very minimal movement of the coronary arteries. So from this, I'm not an interventional, I'm ICU doctors, but whether when we see all these factors, shouldn't we already put the ECMO at that time, say ECMO, not Impella, because of hypoxemia, ECMO at that time to before doing the angiography, or should we wait until we have the cardiac arrest and other things like this?
I think your points are excellent. Some of the fundamentals are, what's the heart rate, what's the blood pressure doing? I actually met at the first presentation at the regional center before being transferred over. It was perhaps more subtle, but...
Sorry, can I ask one more question as well? Dr. Boone, great presentation and great case. I think one question that I had, and for the panel as well, is the extent of revascularization that was done up front and then later in the case as well. We talk about in cardiogenic shock how we tend to go after the culprit only, and I think that was the initial intent in this patient also, and then it looks like things deteriorated even after the Impella when we were working on the RCA. But I guess my question is, if you already have the patient completely supported at that point at VA ECMO, should we still only be going after the culprit at that point, or should we be trying to do a complete revascularization?
Is that a question for me or for the...
That's a difficult question. Anyone want to take that on?
So I don't think the answer to that is entirely clear. I think it'll be probably on a case-to-case basis. You could tackle it at the same time depending on your contrast load, depending on the radiation, depending on exactly how the patient is doing, how many pressors you were at that point, and how you're flowing on the ECMO. So it's hard to have, I think, it's basically your gestalt at that point, right? So if you've already revascularized two vessels, the RCA and the LAD, the patients had a fair bit of contrast already, And if he's doing stable, if he's stable and you're on ECMO and flowing fine, you could probably stop and bring him back. The essence really is to make sure, as Dr. Tirani pointed out yesterday, is to come back and do complete revascularization, which was very appropriately done here. I think he was brought back for the Ramus intervention also because he was having VT episodes, but also for complete revascularization. And the CTO, the CIRC was attempted and was noted to be a CTO, and as you mentioned yesterday, it doesn't have to be done at the index procedure. It can be tackled later on. Nobody died from a CTO in an acute case ever. So I think this case, in some ways, sums up a lot of the stuff that we've talked about before, identifying which stage you're in, and it doesn't mean that you start in one stage, you stay in that stage. Things can rapidly de-escalate, and as you saw here, things went down rather quickly from stage B or C to stage E, and then appropriately so, interventions were done, escalation of care was done from one device, and then at that point, towards the end of the case, you guys noticed that you were on high-dose pressors despite being on an Impella, and so the point was to escalate down, escalate to another device, and essentially this became an ECPella at that point, as we discussed in the forum yesterday. A lot of the times when we have ECPella, it's not so much that we are venting and unloading after the ECMO is done. It's usually the reverse. There's an Impella placed first, and then you're escalating on top of an Impella, and that's what usually becomes the ECPella that we talk about. This is another example of that. And I think, to me, I think this is a good example of how a shock center is handling cases. So although the index culprit lesion looked to be the LAD, escalation was PCI was done to the LAD. There was obviously issues. Escalation was done to appropriate devices. Complete revascularization was attempted. CTO was just probed but not really pushed, and the patient had a good outcome. The access to care that we have in a facility like this gives you the options like this, but this is not routinely possible in every case. So I think that's the important message of this case to me personally, is to be able to do this in a systematic manner and offer all the treatments with the devices you have.
Dr. Carr?
I think this brings out two important points to what Dr. Bailey said. The danger of the SCI classification is oversimplification and using it as a therapeutic tool. Like he said very clearly, this was not stage B. If anyone examined this patient, this was not stage B heart failure. But because of the few numbers, it's so easy to say stage B. And then you somehow get lulled into a false sense of security. Stage B is fine. A patient who's tachycardic having S3 gallop is hypoxemic, by no means is stage B. And that is the danger. I think we have to have granularity. Yesterday, you spoke to Dr. Munch, who said it very nicely. This is a great tool to triage initially when it hits the primary care or primary hospital. But once it comes to the shock center, you have to have a dynamic score, something else, to ascertain how quickly what we need to do. But having said that, since we have so many tools, I remember Lombardi saying that it's better to avoid these complications by good judgment than try to bail out with good skills. This patient, if it was recognized earlier, of course, this was a very difficult case. I agree with Sukhdeep. What he said is, Monday morning quarterbacking is easy, but when you're 2 o'clock at night, you're trying to do a calcified lesion in a crashing patient, you've got to do what you got to do. But I think answering his question, whether you'll do the full revascularization now, you're not going to be putting ECMO 3 times on this patient. So you have the patient on ECMO, you're stable. Now, you may not do the same night. You're 2 o'clock at night, you work for 3.5 hours, you've done 2 cases, the patient's stable. You go out and bring him in a day or 2, that's fair. But before you take out the ECMO, if there is any doubts, now if the patient is completely stable hemodynamically, you can take it out and do it a few days later. But if there's any doubts about hemodynamics or electrical stability, then do it while he's still on support, because now he's on support. It's better to do that. So I think you have to keep this decision-making simple, but at the same time not get so oversimplified that you get lulled into a false sense of security.
I have to say, I'm agree with all the comments. One is the radial approach. If you are thinking this is a B or C, and the second part will be, yes, there was a good escalation of therapy, but we have to think if it's better to escalate or de-escalate therapy. And I think in that case, I should be thinking, I'm not interventional, but I was thinking radial approach will be probably the second option, will be femoral, and then escalation, instead of escalation, go to de-escalation and do first the VA ECMO and then de-escalate therapy.
And that statement needs to be corrected. You just said it in the mentioning that you took radial because there's some mortality benefit. Not a single trial has shown in STEMI whether radial or femoral approach has any benefit, except for a little bleeding issues in the radial being little less, but statistically not significant, insignificant.
Well, on that note, thank you for a wonderful session to our presenters and our faculty. Thank you.